Smith the hour, and the guests are all seated ready for this important conversation. I hope you could be part of us. As always, the hashtag is the Daily Report, as well as the People's Court. Hashtag People's Court at Linda_Lela TV47KE. I'll be sampling some of your questions as we proceed with the broadcast. Tell us your situation, where it is that you are at, and what the people are feeling generally as to these concerns that are being raised that in no time we're going to have shortage of ARVs. There are some people who say they have already begun experiencing this, but the government then maintains that we are not badly off as a country. This occasioned by that halting of funding that is by the U.S. government and of course to USAID as well as PEFRA. And a majority of people then would ask, what does Africa need to do to ensure that they position themselves such that when such orders then come on board, they are able to manage as opposed to always depending on funding. And so on this very set, we are delighted to have Dr. Shamsa Ahmed on my farthest left. Dr. Shamsa is the head of infectious disease in Pisha Hospital. Thank you so much for creating time to be here with us this evening. And then we also have Angela Langat, MBS, the Director, National Endemic Disease Control Council. Thank you so much for creating time. We equally have Kaikai Naipamei, CEO Youth Champions for SDGs, Sustainable Development Goals. Asante Sana as well for creating time. And last but not least on this side, we have Dr. Samuel Kinyanjui, the Country Director of that is AIDS Healthcare Foundation, AHF. Asante Sana for creating time once again. And on this other side of the audience, I'll be giving them the microphone as they get to introduce themselves. But lazima tusalimie the King. The King is in the house as well. He'll be introducing himself. Thank you so much, King, for creating time. I think this is a moment that then the world, the country is eagerly waiting to hear from you and what we suppose would be the direction, even as we continue to get worried as to the concerns that have been raised by the World Health Organization. And since we have specialists on board, I think I will go straight to it and, of course, just get to ask some of these pertinent questions as to where we are at as a country. I think then this goes straight to you, Angela.
Yes. Thank you, Linda, for this opportunity to be in this People's Court. This is my first time.
Yes, it's basically the first time.
Yes, it's my first time.
Here. No, yes. Only one gentleman. You've been here before, sir.
Yes.
Yes.
Okay. So let me do a status analysis of where we are at as a country.
And I hope you can project so that at least this other side.
Oh, so I hope you can hear me. I speak very softly.
Oh.
So President Donald Trump signs an executive order on the 20th of January, 14169. And then subsequent to that, that executive order has a 90 period, which ends on the 19th of April. And he wants to reevaluate his foreign aid. Once he signs that executive order, there are 7 other pronouncements that happen where there's a stop work order. So people are either released from work, there's disruption of services. So that is what happens. And of course, that affects the whole world, including Kenya. So as a country, last week, we were a bit worried of one of the drugs for our children, nevirapine. And it's because the drug was available in the country, but we were unable to access it because the coordination of our supply chain is done through 3 mechanisms. The Kenya Medical Supplies Authority, which is KEMSA, Mission for Essential Drugs and Supplies, that's MEDS, and then the Ministry of Health. So the drugs were at MEDS, but we were unable to access them because of that temporary disruption in terms of supply chain. So MEDS could not distribute the drugs and the government could not access the drugs. But as of last week on Friday, remember, the Cabinet Secretary for Health flagged off some medicines. And last week, MEDS received communication from DC to allow them to be able to draw down money and do the distribution for the drugs. So as we speak right now, the drugs are being distributed. So if I can give you some statistics,
right,
for TLD, the quantities available are over 2 million packs, and the stock level is 4.7 months of stock.
Okay.
As of now. Months.
Okay.
The next assignment, the consignment is over 4.8 million packs.
Okay.
And by the end of June, we'll have a stock of 11 months.
Okay.
So from where we sit, it is true. We have secured stock levels for the whole country from several months now up to close to 2 years.
Right.
So there should not be any panic in the country as we speak.
Okay.
Last week we were a bit worried because, of course, the disruption of PEPFAR-supported programs was to the tune of 8 billion Kenya shillings for HIV commodities.
Okay.
But then now that has started to unlock itself. Yes.
Okay, and so we're just looking at this year.
Yes.
If the executive order were to stand, then what?
We have stock for 11 months.
11 months.
Yes.
11 months is as good as, you'd say, a year, and now crossing over.
So we have 3 funding mechanisms. There's Ministry of Health.
Okay.
That's government. And then we have Global Fund, and then we have U.S. government.
Okay.
So the U.S. government is 8.9.
Right.
Then we have Global Fund and the ministry.
Standing at what percentages?
So the Global
US is
Fund,
8.9?
Yes, Global Fund and USG, we've had a very heavily land response on that too,
okay,
of 80%, and then the government 20%. But notwithstanding, in terms of stock levels, we are fine.
Okay.
So there should be not any panic at that.
So if any delays in different parts of the country, this was just occasioned
This was occasioned by the fact that there was a temporary stop.
Okay.
But now, because of what happened last week, MEDSNA is able to do the distribution.
Okay.
The government is also trying to ensure we expedite some of the procurement for the different drugs.
All right.
Yes.
I hope you have seen the report by the World Health Organization that raises concern that there are possibilities that this could, cause alarm, that is for countries like Haiti, Kenya, Lesotho, South Sudan, Burkina Faso, Mali, Nigeria, and Ukraine. And this is the World Health Organization that is highlighting these concerns. They go ahead to say that this could undo 20 years of the progress that we have made as to addressing, the concerns of HIV and AIDS. And of course, this is the Secretary General himself, Tedros, who goes ahead again to say that it could easily lead to 10 million additional HIV cases and 3 million HIV-related deaths, that is in the mentioned countries or even globally. What does it mean when we're going to speak about the fact that we are good and the World Health Organization then highlights this? Whom should we trust? Perhaps to come to you, Senior.
So thank you very much. Like you've already said, my name is Dr. Kinyanjui, Country Director of AIDS Healthcare Foundation. And they said numbers don't lie.
Okay.
And I just wanted to paint the scenario because I tend to agree with Tedros and WHO. Because when the numbers, if you look at some study that was done during COVID time in the year after COVID, the year 2022, that's printed in the Science, the journal Science, they were able to demonstrate that in any Sub-Saharan African countries during that time, interruptions of treatment resulted in an increase in possibility of transmission by a factor of 1.6%, and mortality increased by 1.06. Transmission from mother to child increased by, at the same time, at 1.6. When you say those numbers, they don't look big, but if you just put them in a grid, and which we did here, in Kenya, this would mean that 1 year of half the year disruption for nearly between 40 and 50% of the people would increase the number of, we're using 2023 data, we started with the year with about 8,000 children born to HIV mother who also turned positive. This disruption would increase that number by an additional 5,040.
Okay.
And a subsequent year would move that number from 8,000 to 21,000. And by the third year, we would already be looking at more than 34,000.
Right.
These are numbers we had 10 years back. So 3 years of disruption would easily return us to where we were in 2014 or 2015. If you look at the total number of additional cases of new infection for the country, we're looking at from 22,000, this number would shoot back to over 90,000 in a year. This is where we were, I think, around 2011 or 2010.
Okay.
If you look at the numbers in cash, right now, any additional case of HIV per year costs the government and stakeholders about 15,000 per year in terms of cost. So the 22,000 that we got last year will cost government and its partners almost 300 million. But you translate that one to another 3 years with the disruption, this number can easily bulge to nearly 1.9 billion.
Do you suppose as a country we're ready for that? Bulging and...
Definitely we are not.
Definitely we're not. Interesting.
Definitely we are not.
And we'll be coming to Dr. Shamsa to understand what, the private sector looks like. But before then, we come to you, Naipame. The Sustainable Development Goals will automatically, adversely be affected by these numbers that, are talking about, retrogressive approaches where then we will go back from what it is that are the gains that we have made. What do you make of this? What do you think, this would affect or how this would actually impact, and especially on the youth, who equally we have a huge number, as of course highlighted by the medics, that perhaps they could be holding the highest number of cases that is on HIV and AIDS.
Thank you very much for having me. Yeah, of course, Kenya has progressed so much in SDG 3, which is universal health care coverage. But then the stop of funds for vaccines, majorly, which affects kids and people with HIV, which is what we're talking about, will of course pose a lot of risk, especially to young people, because as the world evolves, we are adapting new cultures. And as we adapt new cultures, we assume in court that the government got it covered. Like before this announcement by the US president, condoms were available in all public universities for free, for both male and female.
Right.
And before this announcement, you could walk to any public hospital and you get a VCT test for free, and you start your medication, if any. But then if the 11 months stock are over, and maybe the country doesn't have the 1.9 billion for the new people who have gotten an infection, it will pose a great risk to the young people, given that we party a lot. Our generation is a party generation. So as a champion for SDG, what we will call for is that we get to have more conversations and more training for the young people to be responsible for their health and behaviors, because that is the safest way for individuals who are not yet affected. But those who are affected then, maybe there is a light at the end of the tunnel, given that we have 11 months stock, which the government can figure out. And also the appropriation bill, which is signed the other day, there is an increase of around 13 billion or so to the Ministry of Health. Hopefully, it will cater for the vaccines and the most important medication needed in the country.
All right, and I'm glad we have a specialist here so that they can help us, understand this better. Dr. Ahmed, what is the situation like that is for the private sector? Because then we want to look in such, a moment which then appears like pretty much a global crisis. We want to look at it, lenses of basically, the health sector, as opposed to, the health sector where there's the private sector and then there's the public sector. What is the situation like? How different is it? Or perhaps would we say that we are sailing in the same boat and therefore this alarm raised then affects us across?
So thank you for having me. So I run an HIV clinic at the MP Shah Hospital. So that's a completely private institution.
Okay.
And usually the concept is you would think that it's a private hospital, so they have lots of money. These are things that are not going to affect them. But the truth is we feed into the same procurement, we feed into the same supply chain.
Yeah.
And that's how even in a private hospital, you'll still be able to provide these services for free, meaning you can get your ARVs for free, you can still get some of your lab tests and things done for free, because we work hand in hand. The private sector responded the same way. We had the same panic when we saw that executive order. It's nice that we're having this discussion now. Even Angela and I were talking that there's steps that you can see the government is doing, but at that time we all panicked. But you see, this has happened before. We're getting stressed out by this particular president, but even during the Obama administration, 2016, we had something similar. They cut funding, we panicked, people talked to them and they managed to give it back to us. 2019, we had something similar with blood. The US pulled back funding for blood transfusion. We went through panic, we kind of got over that. I think what we should be saying now is in terms of public and private, how can we leverage these partnerships so that we stop panicking every time somebody pulls back from us?
Right.
Because what this keeps revealing is that we have donor dependence. So we have big things that are running in our country that we can't sustain if someone decides they don't like us anymore or they just don't feel we're important. We have donor concentration. So what we've done is whoever is funding us, we've got maybe 3 or 4 people. So you see, you have USAID or you have the US government, and then we say Global Fund, but it's the US that also gives money to Global Fund.
Right.
Then you have the UK, and you've seen even the UK has pulled back aid on certain things the other day. Then you have Gavi, but Gavi targets maybe certain things, vaccines. So what we're seeing is, as we're coming up with these solutions, this crisis management, what we're supposed to be thinking about is what's our sustainability and what is our transition plans.
Okay.
So a lot, I think, as we go forward is public-private partnerships need to be better. So there's a way we can support each other whenever we're having shortages on this side and that side.
Fair enough. And we come to this side. First of all, King Hujambo. Wasalama. When you hear about all this talk, what gets into your mind? And you know, you've been traversing the different parts of the country, just talking about abstinence, you know, use of condom, and now here we are.
This is a big shock to most of us that survive in the area of HIV for the last almost 30 years or 20 years. We have nothing else that we can do apart from campaigning on safer sex. That's what we have done for a long time. And I think this is one thing that will take us back to the beginning of HIV. Because now people that have been getting ARVs or people who have been so comfortable in the world of HIV/AIDS will not be comfortable anymore. They will start aiding. Now we are going to see stigma coming back. And I want to put it very serious that HIV does not have a local name in any community. Like in Kikuyu community, HIV is called Mokingo because people were they were slimming and the neck was pulling. Now, if we miss HIV and we miss this prevention strategy that have been doing very well, people will start pointing people and stigmatizing people. So we'll go back to the drawing board. We'll do now a lot of HIV awareness again. About young people, they are so comfortable with HIV because a lot of young people have been born with HIV. Like HIV is 40 years. Now somebody born with HIV, living with 35 years with HIV is comfortable and not having stigma. And even people cannot identify that person in the community. So if we withdraw these and disrupt the system, we are going to have a very great impact in our society. Counting that 70% of people living with HIV/AIDS, the whole world, are in Africa. We have the biggest burden, and we are suffering. Like now, AHF have been giving us free condom. So if the government doesn't have condom, AHF have been giving us condom for free. We are going for weekend. Vasha. Vasha is a great thing.
Yes, for the rally thing. Yeah?
Yes, I'm preparing myself to go there, but I have no condom
to give out.
Yes.
So then we must admit that somehow we have been affected.
In fact, we don't even have people to. For the first time, we'll miss people like AHF. I don't know whether they are coming. National AIDS Control Council. are not coming, we are not going to have the main characters who help us at least to give information about HIV. These are very big bro for our campaign.
And because the representatives, some of the representatives are here, they'll tell us whether they'll be coming or not. But then I think I'm tempted to come back to you, but to respond to that, because then no matter how much we want to say that all is well, it appears that all is actually not well.
Okay, so let me backtrack a bit. As Dr. Shamsa was saying, the conversation of sustainability has been with us for 15 years.
Yes.
Okay? We've been talking about how to sustainably have a good response. Okay? And for the last 15 years, there's been that conversation. And as she says, it's not the first time that we've had a disruption like this before. But there is hope. For the first time, as a country, we developed an operational plan to guide the country to get ready for this process.
Okay.
What now has happened is that we were moving at gear 3, but now we have to move at gear 7.
Okay.
It's like you're walking with a friend and the friend bolts and you have to keep walking. So this, our strategy as government is to ensure that the next AIDS framework, because they happen in 5 years cycle, that we're able to ensure that service delivery and systems, governance, healthcare financing, we have all our eggs in the right basket, and make sure that we are not relying on this 80%, because 80% is huge.
Yeah.
So we developed this operational plan, and it was launched by the Cabinet Secretary on the 1st of December. And this plan, we are now in phase 2, and we are already rolling the ball.
Okay.
We've developed tools to collect data so that we're able to come up with a plan that can guide the country and also have county governments also in terms of implementation plans.
Okay.
So we are doing this differently because a few years ago we developed something called the Kenya Health Transition Plan. And we said that we needed X number of commodities, we needed this kind of human resources for health. But then again, that document, because of the amounts of money that was there, people were very scared about the amounts. Yes.
Dr. Samuel seems to disagree, but allow me to, engage the lady and the gentleman as well. Nataka gentleman aanze ama mnataka lady? If ladies first, eh? Ladies, she has a mic. Let us agree that we all are affected in a way, because then, of course, you probably know someone who's infected, or you are infected, or maybe a family member, a friend, and everything, is affected. And therefore, when we're having these conversations, we must really bring them down to the level of the homestead, to the localities that we are in. What do you make of the situation? US wakisema now we pull off the funding, and all of a sudden there's panic all over. Do you suppose that the government has addressed this matter in the best manner, such that hata watu pale kwa ground then are at peace that there's no cause for alarm?
Thank you so much. Vera. I'm a fear mentor at a facility.
Yeah.
Okay, I'll be talking out of experience. Since the USID thing started, it has not been easy because there is tension from the recipients of care. They always have questions. They come to you. They want to know much. Now I'm coming from the community in Dandora. Na hapo kuna watu, like, they always want to know things. So the clients will come to you as an individual because they know you are in that facility. You just have to know, because saizo wendo unawafanyanga follow up, wendo unawafuatanga, wakikuja their meds. So they'll always come, they want to know much, they want to know if there are drugs. Right. So it has been a challenge because of the tension from the recipients of care. And also in the facility, we've been lacking some services like VL uptake, the viral load uptake.
Hold the mic, Vizuri.
And again, there are no prophylaxis for the kids.
Okay.
Yeah.
Up until,
the mothers.
Up until when? Because then Angela here says that at least that has been addressed.
Yeah, the ARVs
The latest
are there.
you experienced a concern?
Latest we have experienced in our facility, there are no prophylaxis for the children.
Until today?
Yeah, from last week.
From last week?
Yeah.
Okay, interesting. Gentlemen, you can go first.
Yes. Kwa majina naitwa Franklin Wanyama, na mimi kenye naweza sema ni since hii story itokee venye ambassador amesema, there is a lot of stigma yenye imekama up. Ile stigma yenye tumejaribu kuchapana nayo for long, unapata for now ni kama inaanza kurudi.
Okay.
Na inarudi na with a lot of energy, whereby you find like the community inasema like sasa dawa zikikosekana tutawajua. Cause sasa wataanza kuisha as in the way the community is putting it.
Yeah.
It's totally making most of the HIV positive people much afraid. So unapata like sai mtu HIV positive anaweza zunguka facilities ku collect dawa. Unapata anatoka hii anaenda anachukua anasema ilipotea, anaenda kwa hii ingine.
So that they have a stock.
Yeah, kuweka stock because they don't know of what is coming kwa sababu pia social media na nini, there is a lot that is being given. Some is true, some is wrong. But so unapata huyu anataka akuwe na hizo dawa, so ana rotate several facilities ku collect just in case anything.
And there's an opening to that. Ili unaweza enda kwa hii facility na hiyo ingine. That's allowed, yeah? That really is allowed?
No, it's not allowed.
It is not allowed. No. Interesting. Okay, we'll be coming back to that.
Okay, it's not allowed, but you know now when they come, they don't tell you direct like they have medication. Watakwambia maybe zilipotea or maybe wanachukulianga facility ingine or maybe walikuwa na travel. So even if it's not allowed, but those are some of the tactics they are using, of which I feel like we might go some steps backward if it's not addressed. Another thing is also, let's say like me, I was born HIV positive. Kuna services zenye nilikuwa nikipata pale facility. In terms of maybe pia tukikutana, kuna some session, kuna pale adherence counselor, kuna several people. Apart from, you know, I tend to see like, inaonekana like HIV ni kuchukua tu hiyo tembe na kumeza. It's not all about kumeza tembe. There is some issues that need to be addressed. In terms of adherence counselors, in terms of peer educators, in terms of youth friendly. So I feel like there is a lot that needs to be addressed other than dawa tu. It's not all about dawa tu. You need to also know, where is this person coming from? What are the challenges is he or she going through? Mental issues. So let's
have this been addressed previously? I mean, before this order that we're talking about?
Yeah, it was there kwa sababu tulikuwa na adherence counselors, tulikuwa na peer educators, tulikuwa na a lot of people who are at the facility trying to help out. So unapata like hiyo support yenye nilipata until where I am now, unapata like it's tending to be totally different. Kwa sababu nimesikia kuna kitu inataka kufanyika inaitwa integration.
Right.
We have not been defined well. Integration itafanywa aje? I'm much afraid whereby tuseme napelekwa county hospital.
Yes.
Hii county hospital tutakuwa tunachukulia dawa famasi moja. Na dawa zetu ndio hizi zimeandikwa kwa social media. Kila mtu anajua hii chupa ni ARVs. How will I pick my medication at the pharmacy level? So as much as we are trying to work on it, we need to polish a lot that needs to be worked on. Kwa sababu unapata kama sisi wanaume, sisi hatubebangi mabags kwenda facility. Mimi ndachukua hiyo chupa nitokeleze. But at the end of the day nikishapata na pale na watu wenye na wajua, how will it happen? The stigma will grow. So we need to think about it.
Interesting. Okay,
thank you for having me. I'm Smiles, peer educator and an OTZ champion. Okay, speaking about the USAID and the program fund, yeah, it has really cost a lot. Speaking as he has said about integration, for me I've seen, because I happened to travel last week. I'm from Nakuru, so I happened to pass there to the facility I used to go. So the facility is already integrated, and the HIV clients are supposed to register with 200 shillings at the facility. ndio aende kwa OPD aonekane na daktari. So inaturudisha back to the stigma time juu most of the clients hawako used to that program thing.
Okay.
And the money hawana juu each and every time unaenda clinic unatoa hiyo 200 kujiregister.
Okay.
Yeah, so another thing is the youth friendly things. Yeah, I have been working with the youth. I have a group connecting youths countrywide, and speaking back then, we had youth friendly activities, and we were used to be supported by the programs. As we said, about the Safari Rally, we used to go as Team Maisha Youth and OTZ. We go there, distribute condoms, and give awareness about how to prevent STIs. But since that stop order came, we have no information. We are there lacking behind.
Okay.
We have no condoms to distribute to the communities, and awareness is not taking place at the society. So you find like most of the cases, the youths pocket themselves, visit a place,
Okay.
have fun there as they are educating the communities.
Okay.
Yeah.
All right. Yes, you can say something before we cross over to get some response on this side.
Okay, I'm Maxwell, a peer educator. Now, this peer educator thing, we have no idea where the peer educators are falling when it comes to integration.
Okay.
Because even the clinical officers, everyone knew the CCC is being dissolved. So you have no idea where, the peer educator is there. We start from the peer educators going up. Right now, we have no idea.
Okay.
We don't know where the peer educators are. But the foundation of that CCC, when a new client comes in, test positive, when he's tested or she tests positive, the first person is a peer educator.
Peer educator.
Yeah.
Okay.
But right now, when you test some hospitals, you test positive, you just move around. You move around to the clinician, pharmacy, and then you go home.
Could you please enlighten the masses just what a peer educator does, like you say? I mean, prior to this integration conversation, where were you positioned? And I mean, are there any form of payments that are made to peer educators? Is it something that you voluntarily do? Or what exactly goes on?
Okay, a peer educator is like
Are you under an organization mostly?
You volunteer under an organization to educate the people who are new to that journey, the ones who are continuing to take their medication.
Okay.
Because some, you might find some are taking their medication, then it comes a time they stop.
Yeah.
So you have to follow up on them.
Some of them would actually refuse from the onset, yes.
But right now, you are finding that even the person who you are pushing to take the medication, right now when all the organization fall, sahi hakutakuwa na mtu anafuata huyo mtu.
Okay.
Unaona? Sasa utapata watu sasa hakuna mtu anafuatilia. Kila mtu ni kivyake. Kitaka kumeza dawa, ukose kumeza, no one cares.
Interesting. Very important, concerns raised here. And nazile vitu za ground, basically what it is that we want to hear. We perhaps come back to you and just ask this very questions that they are asking as to this element of integration and this, withdrawal funding, the impact that, it would bring eventually. Because in as much as we want to say that we are in that process of making sure that we are liberated, reality is that from what they say, the impact is being felt on ground. And therefore, there's a huge gap that needs to be covered.
When you're looking at what was cut, you see, like we're saying, the show is talking about ARVs, but when you look what was cut and what was allowed,
yes,
there's a whole cascade. When you start with just awareness in the community. Remember, we even have community health workers, yeah? We have the peer educators, you have mentors, you have many people who come from the community who actually do the work of getting the community to buy into what all these donors are saying. And at the end of the day, HIV is a trust game. You know, we've had to build trust with these patients who've been with us. And right now, what we've done is we've broken that trust. It doesn't matter whether the funding was coming from somewhere else. We are the faces of whatever it is that we've been doing. So we've broken that trust.
Okay.
And then in a way, we're coming back and saying, no, don't worry, we'll sort it out. But like they're saying, you're going to lose a whole cohort. And we've lost patients already. Yeah, we've lost patients to other places to see whether they're literally going to other towns to see if they can get medication. So we've broken that trust. So when we're saying, yes, we've got medication and we've got this, but when we've broken that trust and broken this whole set of people who support a single individual who have HIV, I don't think we've addressed that. And you've got the actual people telling you we've not addressed that. What we've done is we don't have medication. You've missed it for a little while. We've got the medication back. But in our sustainability plan, I don't think any of this has been addressed. And again, you see, that would be the difference, unfortunately, between public and private. So that if you did have a counselor and you have, your mentorship and you have your groups, those things at the private, those would continue because you see your payroll and your support would be coming from that hospital. But you see, when you look at these programs, when they started, remember, they came from a donor who decided this is your problem and this is how you people are going to solve it. And we're going to give you a lot of money. We'll build the hospital, we'll pay the doctor, we'll pay this. But the moment they took away that money, that thing would die. After a little while, it became, let's make it slightly sustainable, meaning I'll pay Shamsa for 3 years, but at the last 2 years, your facility better know how they're going to take her on. So that's what we need to be looking at, that even if suddenly someone turns around and says they want to fund this, or the government says they want to fund this, we need to know how we're going to be able to replace all of these gaps. This is really devastating. I hope the people who are listening are really listening to what is going on here. You know, I trained in Kenyatta for my undergraduate, At that time, that was what you called AIDS. Those were the patients that you were seeing. By the time I was going back for my master's, that's not what you saw. Because that's the kind of gains that we made. So it is devastating to think that in another 4 years, we're going to go back.
Reversing all this.
Yes, so as much as we talk about the medication, everything they're saying is extremely, extremely important. So as we talk about this, we really need to know how we're going to sort out all of these issues as well.
And I mean, that would have been my question, because then reality is that we have a long-term health consequence that would come with this. And the question then would be, just how is the government planning to make sure that they bridge all this gap? And like we had begun by saying, the conversation revolved around ARV and the concerns that we have. But listening to this, lady and gentlemen, the reality is that, like Dr. says, it goes beyond that. How do we manage this?
So thank you very much, Linda. I had my notes here that say a road to sustainable healthcare. I want to strongly agree first with my colleagues from that are telling us what's happening on the ground, because we also are working in 12 counties and we've gotten the same reports. It's generally not allowable to take medication from various facilities.
Yes, that was...
But when there is this level of uncertainty, Kenyans will not sit back and wait. So what they do is that they want to stockpile. And therefore, they've been going around with all sorts of stories and collecting medications from various facilities.
And there are chances that maybe some are actually paying for that because, I mean...
No, they're not paying.
But there's no possibility. They're just
stockpiling because I'm on transit. Or my medication. They can even come to the same facility and say, oh, you know, I got robbed and my bag went and it had my meds. Then you replace for them, not knowing they are stockpiling. So they may stockpile and we may end up even with some of the drug wasted because they may expire, because if the supply is as good as we are getting to know from the government. But I wanted to address the real loss that we've had with this stop order. Number one is that the cost of delivering health services, not just HIV, the biggest cost is the HR, is the staff. That will account for almost 70% of the budget. And with it, we look at the government structure as only basically starts with the nurse. And therefore it misses out. The government does not have a job description for a peer mentor, for a mentor educator, even for community health worker they don't employ. And as a result, all these support structure that links, that anchors a new client into this care, lifelong care, is missing. And that's what they were explaining. That is a HIV diagnosis is a devastating finding about your life. And therefore, you need a stable hand, somebody who will walk with you, tell you, I have been here.
Right.
And I was like you, and I am here. And I will walk with you. If you have any question that you cannot ask the doctors, ask me. If you need somebody to help you navigate, ask me. And that's what this role that's brought by this cadre we call mentor mothers, for if you are dealing with the mothers who have just given birth, who were expectant, mentor fathers, they are there. We have peer educators, and they're strongly important, especially for the teenagers. So we've lost that. The other thing that we've not mentioned and is critical, it is also the lab works. It is important to be able to investigate and know, are these medications we're giving to our clients, are they a help or are they damaging their organs? And that right now, over the months, we've been stockpiling samples from clients for viral load, CD4 count, for children, EID. We've been stockpiling. As a result, they say we have lab kits that should last us 4 months, but we have been stockpiling for months. We may utilize all of it in the next 1 month. My sister there already said that while the drugs were distributed since Friday, or flagged off since Friday, the pipeline takes time. That's why she's saying on the ground, they are yet to be felt, because they have to be received at the county level. From the county level now, then they are distributed. That's why even some facilities have not received. When they have been received, there's a whole process to get them ready to where they are needed.
Beautiful.
Yes.
Okay, and allow us to take a quick short break. It's exactly 30 minutes past the top of the hour, and then we come back, and Ipame will be coming back to you as to just how much of involvement and engagement of the youth is happening as to addressing this, creating awareness, as well as just making sure that the youth test themselves, that they engage in safe sex and so much more, because then ultimately we are looking at a sustainable development goals. Do we suppose that we're going to have a future that is well catered for, with a healthy youth that can take up that, right? After this break.